I'm working right now at the Center for Advancing Research in Transportation, Emissions, Energy and Health. And it's a 5-partner center. So our health partners are the Johns Hopkins University. We're working with the University of Texas, El Paso, Georgia Tech, and University of California, Riverside. And our mission really is to bring transportation and health researchers together to do research around transportation emissions and health. So it was a really good fit for my transition. So what I want to talk about today, and really I've done this presentation more like an informal discussion presentation, so please do feel free to interrupt me if you have any questions or comments or feedback. But it's just a higher level presentation that I want to show some of the work we've been doing in the past few years, and I've structured it in 3 parts. So the first part, I'm going to show some of the latest, most up-to-date evidence on the linkages between transport and health, and especially environmental exposures related to transportation and health outcomes. So I'm going to just overview the literature very, very broadly. In the next part, I want to talk about the methods and tools we've used in the past to assess the health impacts of transportation, planning, and policy decisions. So things like health impact assessment, but also quantitative health impact assessment, or as we call it, burden of disease assessment, and show some examples that we did in England and in Barcelona that we're taking further now in the US at a larger scale, and we can talk about that later as well. And the last part is really, I'm going to give it over to you, throw out some questions at you just to stir up some discussion of how we can really advance transportation planning and policy, or public policy in general, to take these health outcomes better into account, because I don't think they're taken into account as they should. So that's my presentation overview. So starting on the linkages between transportation and health. So really, the way I think about this is I think about transportation and health in a rapidly urbanizing world, right? Cities now, so this graph is showing the proportion of population living in urban areas over the years. So this blue line is the world total. This red one is the high-income countries. The middle and low-income countries are these 2 lines. And we see that a lot of people are really becoming urban. And urbanization, obviously transportation planning and policy plays a really important part in this urbanization wave. And both the combination of how we do our transport planning, but also how we plan our cities, can really promote or can really degrade health, as we'll see in the next slides. When I was at a transportation institute and working a lot with transportation planners and engineers, when we thought about health in transportation, we mainly thought about motor vehicle crashes or accidents. That was the thing that was talked about a lot. That was the thing that made it in some of the transportation investment appraisal, partly because death is such a big outcome, such a important outcome, and also in terms of monetary evaluation, the value of statistical life as it goes into investment appraisal is high. So it can actually drive those cost-benefit analysis in a way or another. So we talked a lot about motor vehicle crashes, and globally, these are some numbers coming from the World Bank a couple of years ago. Globally, 1.5 million deaths around the world are because of motor vehicle crashes. Many of these deaths are happening in low and middle income countries, and many of them are happening to vulnerable road users. So not car drivers, but more like pedestrians, cyclists, and people on motorcycles, right? And a lot of injuries. Almost 80 million injuries every year are because of accidents. We also think about, and I feel like this has been more recent when we talk about health and transportation, we think about air pollution and physical inactivity as 2 other pathways that link transport policy and planning and health. And these are really big ones, actually. And in some of the health impact and burden of disease assessment that we've done for cities, we see that the air pollution and physical activity results or impacts are much higher than motor vehicle crashes, 10 times higher in some cities. So these are big ones that's come into the discussion a bit more recently, perhaps a bit more difficult to quantify, especially when it comes to disease linked to these exposures and not just premature mortality or death. Okay? So also these are numbers coming from the World Bank. 184,000 annual global deaths in the world are because of traffic-related air pollution in particular, not just air pollution. This is a very conservative estimate, as they say. It's probably much higher, but this is what these burden of disease assessments are telling us. Now, one thing I'm interested in, and this is some of the work I'm doing right now at TTI, is to try to frame those linkages between transportation and health, and not just think about these things that we've been studying or talking about often, but more about the wider range of pathways and impacts of transportation and health. So this is a graph that's just showing some of the transportation planning and policy decisions, so which mode choice is prevalent, how we choose to travel. More recently, we're talking a lot about technologies and disruptors, especially in the context of autonomous vehicles, electric vehicles, how we plan our infrastructure, what new infrastructure we put, where we spend our maintenance and rehabilitation money, and also obviously land use and the built environment, because they're very tightly linked to transport planning. And all of this we call mobility, and all of these decisions really link to health through different pathways. And I've counted 12 pathways in general. Actually, this has been kind of a incremental process. So when we started this work, we had 6 pathways, then we did a bit more research, they became 8, now we've got 12, right? So the first one is motor vehicle crashes, quite well-established. Physical activity, as I said, and air pollution. These are the things that you see a lot in the literature. But some of the newer ones, and I'm going to show some numbers for the newer ones, like noise and greenhouse gases, heat, green space, community severance, electromagnetic fields, especially when we talk about high-tech vehicles and new technologies, access to healthy food, access to health-promoting opportunities, stress and social exclusion. These are all things that also have an impact on health. They're much more difficult to quantify, and they've been studied much less than the others, but they're there. So it's just part of that framing that we want to make sure we're capturing as many outcomes, as many pathways as possible as there is. And the other thing I just want to make a point of here is that usually we also talk about premature mortality, even when it comes to air pollution and physical activity. A lot of the research we see in environmental epidemiology and health impact assessment is geared toward premature mortality. And again, that kind of makes sense because these are outcomes that have a lot of monetary values in them. They can really drive cost-benefit analysis. But the other issue is that some of the diseases, especially when we're talking about chronic diseases, they're also very impactful. Actually, a couple of weeks ago, I was in San Diego for a meeting for the American Thoracic Society, and it was specially to discuss this, whether we should include things like asthma, for example, the onset of childhood asthma. If we believe that it's caused by air pollution, then that actually has a lot of impact because it's a chronic disease that has no cure. You carry it across your life. So it's just something to keep in mind as I go on with the presentation. So what I'm showing here, as I said, I'm just going to briefly overview some of the latest evidence in environmental epidemiology linking these pathways to health. And the first one I'll start with is air pollution. This is coming from the ESCAPE project in Europe. It's basically looking at over 360,000 participants all across Europe and looking at how much air pollution these participants were exposed to and how their risk of mortality changes or premature mortality changes in relation to their air pollution exposure. And what we see here, this dashed line, means that whether you're exposed or not exposed, your risk is equal. Anything that's on the right means that you have a higher mortality with the increased exposure. Anything on the left means that you have less mortality with a higher exposure, which doesn't make any sense, but you still see some of that statistics when you do the analysis. But overall, the idea with these different cohorts, so each of these dots are a different cohort, are a different group in a different area in Europe. The idea is that we usually like to do what we call a meta-analysis, which is statistically combining these statistical estimates to gain more power, to gain more participants in this final analysis. And when we do this meta-analysis and look at all these participants together, and these are people that have been followed up for almost 14 years, so it's a long time really. We see a 7% increase, so this 107 means there's a 7% increase in the chance of dying prematurely compared to your life expectancy that you should have otherwise with the exposure to PM2.5. And the exposure interval we're talking about here is quite small. It's 5 micrograms per meter cubic. So with every 5 micrograms per meter cubic increase, your risk of dying prematurely is 7% higher. That's important. That's an important number. And the other thing that they did in this study was that they looked at participants who lived in areas where the PM2.5 levels didn't exceed the World Health Organization guidelines or the European Commission guidelines, and they still saw the same relation. So the numbers were similar. So even if you're living in under those safe thresholds, your risk we still see an increased risk. And that's something that's quite consistent. The weight is basically, so each of these dots is a separate study, right? So how much weight this separate study had in this last estimate, this combined estimate, is what the weight is telling you. And usually the weight is inversely proportional to the standard error in the study. And that's usually proportional to how big your study is, how much power. So the bigger the study is, the lower the standard error, the higher the weight that it has in the final estimate, right? But with these pollutants as well, with the kind of models they use for these pollutants, so this is a land use regression model, usually the exposure levels don't really change year on year unless there has been big changes in, say, a new road or a new factory or something massive has changed. So what we've seen also with these models, especially also for NO2, if you look at the exposure in the first year and then look at it again 3 years after, they're quite similar, they're quite consistent. So we can check that, but I'm not sure. But this is the study that has this analysis. And one study that I've done, I'm interested a lot in childhood asthma for the past few years. We've done the same thing with children, so people from birth until 18 years old. And these are all, again, all these points are different studies from all over the world, from the US, from Canada, from Europe, China, all places in Asia. And we just combine them statistically to see what's the risk of a child getting new asthma if they're exposed to traffic-related air pollution. And what we saw in this analysis, and this data set is over 1 million kids, so it's a really strong data set, I think. We saw a 5% increase in the risk of getting new asthma with the increase of NO2 by 4 micrograms per meter cubic. And 4 micrograms, the reason why I chose this interval is that it's just 10% of the WHO guideline, right? So we saw this, and we also looked at other pollutants. We looked at black carbon, which is a better marker for traffic-related air pollution, especially heavy-duty vehicles. We saw the same relations, the same with PM2.5 and the same with PM10. And this study was giving something new in the sense that we know that air pollution makes asthma worse, but we weren't always sure if it actually can give new cases to asthma for children who would have otherwise not have gotten it. So this is what we were saying here. So yes. So this is for air pollution. Of course, there's a list of health outcomes that I'm not covering here that are linked, morbidity outcomes that are linked to air pollution. But the idea not really is to give an exhaustive list, but rather an overview. The other thing was with traffic noise. And I think with traffic noise, some people think that noise is less important than air pollution. And actually, what we're seeing recently is that it's not. And when you look at the burden of disease assessments that I'm going to show you later, the burden of premature mortality and morbidity that you can attribute to noise can be quite comparable to air pollution, especially in dense and noisy cities, right? So this study has been done by colleagues in London and in Barcelona. They looked at 8 million inhabitants of London. They measured, they modeled their road traffic noise, and then they looked at the relationship between all-cause mortality and noise exposure, adjusting for many factors that are considered confounders. So things like socioeconomic deprivation, ethnicity, smoking, even air pollution. And that's important because some of the noise studies that came out before, they don't adjust for air pollution. So people would say, okay, but noise is highly correlated with air pollution near traffic. So is it air pollution or is it noise? So the newer studies are actually adjusting for air pollution to kind of answer that question. So what these guys found was if you live in an area and you're exposed to above 60 decibels of noise, road traffic noise, compared if you live in an area that you're exposed to less than 55 decibels of noise, your risk of all-cause mortality increases by 4%. This is the 104. And this was a statistically significant increase across 8 million inhabitants. So, the numbers are kind of robust. And again, this was adjusted for all these factors, but also to air pollution. And there has been other studies that's come out and consistently showed these results. So that is, if we just go back quickly here, the risk here we're talking about asthma and air pollution is 5%. The risk of noise and premature mortality is 4%. They're quite comparable in terms of percentages. So this study actually was looking at cardiovascular morbidity as well. So it was looking at hospital admissions for heart attacks and other things. They did not find an association in this study, but I know there were other studies that did see associations. But again, I'm kind of showing more about the mortality just because there's more research there and because it's a big outcome, but there's a wide range of literature. And I know that the World Health Organization right now, they're finishing a report on traffic noise and health outcomes. And I think when it's going to come out, that knowledge is just going to be all in one place and disseminated much better. So that's expected. It was expected last year. So it's probably going to come out soon, yeah. So this is with the traffic noise. Now, if we talk about temperature, or as we call it, the heat island effect, and the heat island effect is just the effect that you get in places where the density of structures, buildings, roads is higher than other areas. So actually, there has been studies that show that downtown, the temperatures in downtown compared to outside downtown can be I'm talking Celsius degrees here, 3 Celsius degrees different and up to 10 Celsius degrees different at nighttime. So the temperatures in these places can be much higher because of these kind of heat absorbing structures, right? And on top of that, you get the traffic, and the traffic also releases anthropogenic heat by way of tailpipe emissions, black carbon, causing regional increases in temperature, but also global increases in temperature. So when we think about heat, and this is again a new area of research, heat has been linked, especially, I'm sure everyone here heard about heat waves, right? And increases in hospital admissions when you have heat waves or mortality. And this is a study that looked at 13 cities at almost 74 million people across 13 cities across the world. And I'm just going to focus on the Madrid graph because I like it and because I know Madrid is super hot in the summer. What this is showing on the y-axis is, on this y-axis is the number of deaths. On the x-axis is the temperature. And on this y-axis is the risk, is the relative risk. So the percentage increase in mortality compared to that heat. So what we see here is that when the temperatures are really cold, you have higher risks for mortality when it's really cold, below, say, 5 degrees, below 2 degrees. And then there is an optimal temperature range right here from, I think, around 5 to 20 degrees, where the risk actually goes back to background levels. But then when the temperature starts increasing above 25 and above 30, the risk of death increases in this manner, and like you see in this graph. So that's a new study that's gained a lot of attention, and this is adjusted for many other factors that link to premature mortality, many other confounders. So heat is just gaining a bit more attention. Now with green space, and I think sometimes we don't think of green space as a perhaps transportation factor, but in some way it is, because when you take space for transportation infrastructure, sometimes you're taking it out from greener areas, or you're prioritizing over building public or green spaces. And over the past few years, there has been a lot of work coming out on green space, especially from these guys in Barcelona. And this is, again, a systematic review and a meta-analysis looking at the risk of cardiovascular mortality and green space. So what this is finding across the limited number of studies that looked at green space and mortality, that your risk of premature mortality drops by 4% if you live in an area with a high exposure to green space versus a low exposure to green space. And there's a lot of work around the mechanisms for green space. Actually, we've published a paper last year talking about how actually green space might lead to these outcomes. So there's, for example, a theory called the restoration theory, that we're kind of wired to like green space. We calm down around green space, our blood pressure drops. There are things that green space is probably reducing noise levels, air pollution levels, it's making us physically more active. So there is much more research here that people can refer to if they're interested. Now, with physical activity, again, a meta-analysis, usually I'm showing meta-analysis results because we consider them as the most robust results and just bringing together many different studies, individual studies. So this is a meta-analysis looking at non-vigorous physical activity and all-cause mortality, the risk of all-cause mortality. And it included over, 977,000 people from across the world. And again, if we look at this final estimate, this pooled estimate, and this is a really big reduction in the risk of premature mortality with non-vigorous activity. So what this study found, they found that 2 hours per week or 30 minutes a day of moderate intensity physical activity for 5 days a week, that's as much as I used to walk when I was in Barcelona to get to work, right? So it's something that you can achieve by commuting actively, basically. So if you do that, your risk of mortality reduces by 19%, okay, across these 900,000 people. That's what they found. So again, important statistic, and actually there has been much work in physical activities than some of the other pathways. I think this is quite robust. This is quite consistent if you look at other studies as well. So going back to this, what I just showed some numbers on motor vehicle crashes, on noise, on heat, on physical activity, green space, and air pollution, right? But some of the other things, like when we talk about greenhouse gases, community severance, electromagnetic fields, access, stress, and social exclusion, you don't find much literature there, especially not quantified literature, right? We did a paper last year, and it was looking at 64 transport policy measures and their potential health impacts. And with climate change or greenhouse gases and social exclusion, we found a few studies that gave some numbers or some examples. So for example, with greenhouse gases, the effects happen through thermal stress. Again, this would be also related to the heat effect island through the same mechanisms. Premature mortality, especially in extreme weather events that we're getting many more of them these days, and other pathways. With social exclusion, actually there are a few studies that looked at the risk of premature mortality when you're socially excluded, when you're lonely, when you can't participate in your community, and they show some increases in some studies, but also it's been linked to mental health and well-being. And there are some other indirect effects, right? So if you're socially excluded from certain opportunities, you might not be able to do certain physical activity or go out on a walk with a friend, and all these things really boost your health and well-being. But these pathways are much less quantified, actually. And we haven't been working much on them in environmental epidemiology. And just one final note I want to make here, and you can find much more about it in this chapter we've just written. I've written with my collaborator in Barcelona. I think all of the impacts that I've just talked about are not really proportionally distributed amongst the population. So with air pollution, you see that minorities, usually lower socioeconomic people, they live in areas where the air pollution is higher, where the noise is higher, where the opportunities for physical activity are lower, where green space might be lower. So we've looked at this, and we've done a thorough review in this chapter that I'm not going to go through. But this is well known, but you still see it even in some of the kind of more progressive places, like say Barcelona. You wouldn't think it's true. It's everywhere. Okay, so in this part, I'm just going to go through two tools that we've been using. One of them, not so much, which is just qualitative health impact assessment. I'm sure most of you are aware of this. And the other one is burden of disease assessment, which is basically a quantitative health impact assessment, in my view. And the reason why we were interested in these tools is that a couple of years ago also we had this bigger brainstorming exercise talking about based on the knowledge that we know that links transportation to health, why is it not making its place into planning and policy? Many reasons, of course, but some of the reasons that I want to highlight was the lack of awareness of health impacts by some of the transportation professionals, the lack of awareness by the public, but also an important one was the lack of tools to quantify and cost these impacts. So you can actually perhaps take them into account in transportation investment appraisal. So this is what I'm going to be focusing on right now. And just a note before I start, actually we found out that when we do the burden of disease assessment, we put some numbers and some dollars on these impacts, we get much more attention, both from local policy makers, but also from the public, in terms of press coverage, etc. So in that way, we had a good experience so far. So the first tool, and I haven't used this much, but I just wanted to put it out there just because it's an option. So health impact assessment, the WHO definition of a health impact assessment is a combination of procedures, methods, and tools by which a policy, program, project may be judged to its potential impacts on health and the distribution of these health impacts. So there's also an important part that talks about environmental justice and how these impacts are distributed amongst the population. So if we look at, and this is coming from the Department of Health in the UK, that's kind of what I'm familiar with. And the stages for a qualitative health impact assessment, it looks something like this. You start with screening, and I'm going to show how the screening table looks like next. You identify the health impacts, then you prioritize these health impacts. You analyze these health impacts, whether you can quantify them. That's good. If you can't, you just describe them. And finally, you develop a set of recommendations for policymakers about that program that's being analyzed. So this is what the screening table looks like. It asks questions such as, is the proposal going to have a direct impact on health and well-being? So does it increase air pollution and therefore increases premature mortality, yes or no? Will it have an indirect impact on health and well-being, for example, by changing social, economic, and environmental living conditions that might impact health and well-being? So, for example, can it affect housing, child development, education, climate change, green space, right? Will the proposal affect an individual's ability to improve their own health and well-being? Is it going to affect their ability to be physically active or to access healthy food or green space? Or reduce drinking or smoking? Will there be a change in the demand for or access to health and social care services? And this falls under that access pathway that we talked about that's not usually quantified well. And then, is it going to have an impact on global health is the last one. And these are yes or no answers with some description. That's the first stage of doing this assessment. Now, moving forward, you need to identify these health impacts, and that's stage 2. So you describe the health impacts, but also you describe how you think they're going to be distributed. So will the health impacts affect the whole population, or will the impacts be differential based on socioeconomic status, ethnicities, etc.? Are they going to be irreversible, or can you actually fix them in the future? Are they going to be medium or long term? Are they going to generate public concern? Are they likely to generate synergetic impact? So all these questions fall under the second stage, which is identifying the health impacts. Then you prioritize the health impacts, kind of providing an overview of your decision of prioritization, which impact is more important, and is it positive impact or is it negative? So the other thing is that these assessments should also take positive impacts into account. So if you're doing a bike sharing scheme, if that's the policy you're interested in, it's going to be a lot of positive impacts and some negative impacts. So it needs to be balanced in that way. And then the final 2 stages, the tables look something like this. Just quantify or describe the important health impacts and make some recommendations to improve that policy. And my understanding in the UK is that this process, some local authorities go through it with some of the projects, especially if there is a concern or if there is an appeal for health in those areas. But you don't have to do it, right? You can volunteer to do it, you can be recommended to do it, but it's really, you don't have to do it, right? That's also the case when we talk about quantitative health impact assessment. There is no regulation, at least where I come from, that you need to do these health impact assessments when you want to do a new policy or a big program, which is a shame, really, but it is what it is. Now, the concerns with the qualitative health impact assessments is that other than the fact that it's not regulated, it's also subjective and depends on knowledge. I think whoever is looking at these or filling these lists, they're going to identify what they know of, and then they're not going to identify what they don't know of. So that's depends on the knowledge or the experience of the assessor. So we think that's a problem. It also lacks quantitative estimates. Usually, sometimes you do some quantification, but there's no real framework for quantification. And in that way, that's why we prefer quantitative burden of disease assessment, because you can put numbers on the impacts, and then you can put dollar values on the impacts. And that's the last point, right? So if people are interested more in qualitative versus quantitative health impact assessments, and our experience from certain cities and certain work, we've published this paper as well last year on participatory quantitative health impact assessment of transport and urban planning in cities. And there's much more detail there that I'm not going to go into. But what I want to show you next are two case studies doing quantitative burden of disease assessments. One is actually, both of them are in Bradford in the UK, in the north of England, but we've done the similar exercises in Barcelona as well, and the results look very different in Barcelona. I'll make a comment on that at the end of it. So this was the first paper. We were interested on how many cases of new childhood asthma in Bradford, a relatively clean place, can be linked to traffic-related air pollution. And what we did for this exercise is we went through the full chain of events, starting from the traffic source, so modeling how much traffic and what kind of traffic we have on the roads of Bradford, then their exhaust emissions, and we were interested in nitrogen dioxide and nitrogen oxides. Here, of course, you can do the same exercise for other pollutants. We did then air quality dispersion modeling, and then we assigned exposure to the kids that were in Bradford. Then we did the health impacts modeling, and this was kind of our general framework, and we made some dissemination and recommendations at the end. And I call this full chain health impact assessment just because it's really going through the full chain between the source of the problem and the final health impacts. And I have to say, when we look at burden of disease assessments, they don't usually do this full chain. We usually start somewhere here. So for example, using some monitoring stations to assign air pollution exposures, but not always going back to modeling the traffic and the emissions. And after having gone through this exercise, I know why. It takes a very, very long time, and it's quite complex. But it would be nice if these frameworks are in place so they can be repeated when we need to look at a new policy or a new exposure. So in this case, I'll take you very quickly through the exercise in Bradford. We looked at the Bradford traffic network. It was 4,500 road links that we modeled the traffic on. That was the coverage, almost 1,400 kilometers in coverage. With this traffic model, it was a traffic assignment and simulation model from Leeds, actually developed at Leeds Uni. We estimated the traffic flows in vehicles per hour and the average speed at each of these links per hour, and we did some scaling, so we had it at every hour of the day, right? The model gave us AM peak, inter-peak, PM peak, but we did the scaling across the whole day. After we had these traffic flows and speed, we split the traffic flows based on the proportions of different vehicles we know they're on the road. So for example, passenger cars were 82%. Then we split it into diesel and petrol. This is all year 2009. Now, of course, it's like 50-50. It's changed. Light-duty vehicles, heavy-duty vehicles, buses and coaches and motorcycles. And then for each of these fuels or each of these vehicle classes, we also split it into the different emission standards because each of them have a different emission rate. Then we did the emission modeling, and again, it's a lot of detail, but if people are interested, you can ask. But this is how the emissions looked like across the network. This is in grams per kilometer per second. The darker colors are the higher emissions, so we saw a lot of high emissions across the bigger freeways here, and also around the downtown area. And in this area, this is Shipley, also an area where a lot of people live, a lot of kids live. We put all this information, the emissions, the traffic, into a dispersion model, a Gaussian dispersion model, and we predicted the air pollution concentrations across the whole district. And in terms of assignment, the way, because we were looking at 140,000 children, really there was no way of assigning the exposure at either their residences or where they move. So this was kind of a coarser exercise, and we can talk about which direction I think this level of aggregation made it go, but this is what we did. We just looked at 1,528 output areas. These are the equivalent of census blocks in the US. So they are the smallest geographical block that we have census data for. And at each of these output areas, we assigned an exposure level based on that dispersion model. The next step was finding out how many asthma cases a year in Bradford were happening anyway, were happening due to all causes, and we just found that number from the literature. It was 136 asthma cases per 10,000 persons per year for the age group that we were interested in, so from birth to 18. And what we did after that, and these are just a lot of equations, just as a very standard burden of disease assessment framework, what you do first is you calculate how many cases of asthma are going to happen in that population based on that underlying baseline rate. So that's just the childhood population multiplied by the incidence rate that we found from the literature. Then we scale the risk estimates, so the meta-analysis I showed earlier in the presentation. We scale it to the exposure difference between what we call a counterfactual scenario and the current scenario. The current scenario is how much air pollution those kids are exposed to now. The counterfactual is what if they were not exposed to that air pollution. So we scale our risk based on that difference. Then we calculate something called the population attributable fraction, and the population attributable fraction is just the proportion of morbidity that you can avoid by reducing that risk factor, air pollution, traffic air pollution in this case. Then based on that metric, proportion of attributable fraction, you multiply this number by this number, which is the asthma cases due to all cases, and what you're doing basically is that you're taking a proportion of all those asthma cases that would have happened anyway in Bradford and attributing it back to air pollution based on what we know about the risk between the exposure and the outcome. Again, very standard burden of disease assessment framework. This is how our results look like. And we've done this for black carbon PM2.5 and PM10. I'm not going to show the results here, but for NO2 and NOx, for NO2, we estimated that 394 cases in asthma cases in Bradford a year can be prevented if you eliminate traffic-related air pollution, or air pollution in general, sorry. This number is air pollution in general. This was 22% of all cases that happen in Bradford, so a significant proportion. But when you look at the traffic proportion of that, so just the vehicle emissions related air pollution, it was 7%. So it was much less. In the case of NOx, it was 12%. That's related specifically to traffic air pollution. And then we monetized them. This was a very crude exercise. We just saw how much an asthma case in England causes the National Health Services, and we multiplied that number by how many cases we're getting of asthma. And these are the numbers we got. We got almost $750,000 a year, or if you're looking at NOx, it's over $1 million a year. So also another point that came out of this exercise, that it does matter which pollutant you're looking at, because the numbers can look quite different. And there's a whole other discussion about which pollutant is the most relevant, which pollutant is best to use. So that was the exercise in Bradford about childhood asthma and traffic air pollution. Now, we did another exercise in Bradford, but not just looking at traffic air pollution, looking at some other exposures, which were physical activity, air pollution, noise, heat, and green spaces. And the outcome we were interested in this exercise was premature mortality, right? And the framework we used for this exercise was exactly the same framework we used in terms of how we did the burden of disease assessment, was the framework we used for Bradford. We just calculated the current exposures, we calculated the recommended exposures, and I'll say something about this in a minute. We scaled our risk estimates for the difference in exposure, and we calculated the population attributable fraction and took that out of our mortality cases, and then found out how many mortality cases are actually attributable to these exposure levels. So this is how Bradford looks like when we look at the other exposures. So this is PM 2.5. A lot of air pollution concentration again in the downtown area. This is the noise levels, a lot of concentration of noise in the downtown area. And in this area that I pointed out earlier, this is quite a polluted area because of traffic. And this is the green space. Very little green space around the downtown area where most of the population is, and a lot of green space in these kind of census wards where actually very few people live. It's just more like the rural area. So this exercise included 390,000 adults. We were interested in adults here, anybody above 25 years old. And what we wanted to see was if we in Bradford comply with the WHO guidelines for physical activity, for air pollution, for noise, for green space, it's not really a guideline, but it's a recommendation. If we change from the current case to complying with these recommendations, which are in the case of physical activity, it's 150 minutes of moderate intensity or 75 of vigorous physical activity a week. In the case of PM 2.5, the annual mean is 10 micrograms per meter cubic, 40 in the case of NO2. The daily noise, 55 decibels as a recommendation. Green space, that you should have access to green space within 0.5 hectare, or access to green space within 300 meters, but the green space needs to be bigger than 0.5 hectares. So if in Bradford we go from our current case to complying with all these recommendations, what would happen? How many cases of mortality can we prevent? And in this column, we're just showing the actual current exposures for people in Bradford. So 50%, almost 50% of the population were not sufficiently physically active. The means for air pollution were quite low, partly because we're modeling it. So things like London and Barcelona, again, there are some mentions of improving the quality of life, but the word health, morbidity, mortality, it just doesn't make it to that agenda. So really the question is why, and perhaps what can we do about it to make it more important in the transportation agenda. And this is just an exercise that we did with some transportation practitioners back in England. And we just asked them, what do you plan? What are you told to plan your transportation for? What do you focus on in your planning and your practice? And this is just a word cloud of what came. So health is not there. Air quality is there, which is good. Noise actually came out. But really, it's just not on the agenda. And I think some of the reasons that we talked about when we were discussing this in that paper with the different reasons why it doesn't make it to the transportation agenda. One was that the way we do transportation investment appraisal actually doesn't have a mechanism to take these health impacts into account. And I wonder if you actually can quantify them and cost them. Is there a way to push it into this transportation investment appraisal, into this cost-benefit analysis? What are going to be the problems? Is it going to be that we think there's a lot of uncertainty in these impacts? Or I don't know. It's just a question that I want to throw at you. And of course, you get all the marketing and the big lobbies that are impacting public opinion, and very little out there to kind of drive that agenda to people and tell them that actually these environmental exposures and city planning and planning decisions have a huge impact on your life, right? And I think recently we've been hearing a lot also about technological advancements as solutions to some of these problems, especially when we talk about air pollution, we're talking about electric vehicles. And I'm very skeptical about this, especially like when you look at Europe and its shift from petrol vehicles to diesel vehicles under the umbrella of climate change at the time. It's gone bad. It was thought to be a good technological advancement that's going to solve our issues, but it was exactly the opposite direction. And I wonder, if a good way is to focus on technology to make these improvements rather than think about changing city planning and transport planning. And the same thing with autonomous vehicles. And we've done some work around here, and I think there's a lot of interest here, perhaps not yet in the health impacts or the potential health impacts of these technologies, but I think it's something that needs to be done. There's very little literature on that. So I think I'll just turn the floor to you. I think my question to you all is, are we doing the right research? Are the studies that I showed, are they impactful? Can they be impactful? Can we do something differently to make them more impactful? That's one question. How can we contribute more to a more evidence-based approach? Is the costing, is the quantification, the numbers, can these be game changers when you talk to policymakers or to developers or not? If not, what can we do? And I think some other things that we picked up also when we're always discussing this is stakeholder participation a very important thing? I know it is, but also how can we capitalize on other agenda in the transport sector? So things like, for example, climate change in some places are gaining more traction. And you can talk about the co-benefits, the health co-benefits of climate change. And we did a study of that a couple of years ago in Leeds and actually found out that the co-benefits, not just health, but other co-benefits to other sectors, they're quite big. And they can be, if you monetize them, they could be even more valuable than the actual monetary value of greenhouse gas reductions in those cases. And just finally, so a lot of what I presented today in much, much more detail, we're just publishing a book next month, hopefully, me and Mark Newhousing, Integrating Human Health into Urban and Transport Planning, a framework. It covers a lot of these environmental exposures, a lot of the methods, a lot of the case studies, and at the end of it, it gives a kind of framework into how we can better integrate human health into the urban transport and urban planning. So that's where I want to end. Thanks so much for your attention.